Okay, thank you all for coming. I imagine for some of you it was an extra effort. I appreciate that. But I think you're going to find that it's definitely worth it. I have a really interesting lecture by an expert on the topic. So let me tell you a little bit about Heinz Feldman. He graduated from medical school in 1987 and received his PhD in 1988, both from the University of Marburg in Germany. His postdoctoral research was in the field of virology, filoviruses, and hantaviruses at the Institute of Virology at the University of Marburg, and at the Special Pathogens branch at the CDC in Atlanta, where he held a fellowship from the National Research Council. Following his postdoctoral training, Heinz was an assistant and associate professor at the University of Virology at the University of Marburg. And during this time, he was trained as an infectious disease specialist, and his focus was on laboratory diagnostics. From 1999 to 2008, Dr. Feldman held the position of chief of the Special Pathogens Program of the National Microbiology Laboratory, Public Health Agency of Canada. Since 2008, he has been chief of the Laboratory of Virology and the chief scientist at the Rocky Mountain Lab, BSL-4 laboratories. In addition, he's an associate professor in the Department of Medical Microbiology here at the University of Montana. He's a laboratory expert with high containment viruses. That's why the BSL-4 lab. And he serves as a consultant on viral, hemorrhagic fevers and related pathogens for the World Health Organization. So he's had experience and expertise in outbreak management. I know Sars was one of those experiences that he had. He's a member of national and international professional societies and serves on the editorial board of other journals. Dr. Feldman is an external scientific reviewer for international and national organizations, and he serves as a consultant for high containment laboratories. His professional interest is in the pathogenesis of hemorrhagic fever viruses such as filoviruses, arenaviruses, and bunyaviruses, and other emerging viral pathogens. And his topic tonight is the emergence of MERS, or Middle East Respiratory Syndrome. So please join me in welcoming Dr. Heinz Feldman, who made an extra effort himself to get here all the way from Hamburg.
All right. Good evening. Thank you, Peter, for the nice introduction and the invitation to come up here. Wasn't too bad, actually, on the road. I was worried this morning. Hope it's not going to be too bad to go back south after this, but I think we're going to be fine. What I will do today is I will go a little bit back to SARS. It was just mentioned that I had some impact into the SARS outbreak because the MERS basically emerged at the 10th anniversary of SARS. And just to say this up front, all I'm talking today about is not what we normally do in my laboratory. These coronavirus are positive strand RNA viruses. Normally, we almost exclusively work on negative strand RNA viruses. You may think there's not much of a difference, but for a virologist, there's a big difference. And so this is kind of a new and old field for me. And I want to go first back a little bit to SARS. 2003 is when severe acute respiratory syndrome popped up and was identified as a new coronavirus infecting humans and causing actually the first pandemic of this new millennium. And everybody expected influenza to be the first, but that got beaten by this coronavirus, which basically disappeared after its emergence in 2003 and 2004. This is a chronology of the events And I don't want to go through this. Martin Ansering, a science research writer, has done a lot of nice articles on this that you can look up. Since he writes for Science, they all appeared in the Journal of Science, so you'll find them easily. But I want to point out two things. First of all, February 21st in 2003, a Guangdong physician, which is southern China, falls ill in Hong Kong's Metropole Hotel. And other guests got infected with this new pathogen and then basically started the epidemic or pandemic. And then on March 30th, there was an outbreak, an unusual outbreak in one of the real estates in Hong Kong called Amoy Gardens. And there were more than 300 cases. It was a very unusual setting for the SARS at that time, and actually remained a very unusual setup in the whole SARS history. And I will talk about those briefly, because at my time in Canada, when I was more in public health service, so the lab that in Winnipeg in Canada is more like the Centers for Disease Control here in Atlanta, we investigated those two outbreaks, and I want to quickly run through that with you. So I'll bring you back to Hong Kong, where it all started. And this is the skyline of Hong Kong, for those of you who have been there. And this is what the cases showed. So you have an X-ray of a pretty healthy young adult at admission to hospital. You see first signs of infiltration here on the left side of the lung, and just within a few hours to days, they developed this massive infiltration here. And you can see the airspace is the black space. For those of you who don't know, you can see that that has gotten quite small, and you see all this white area here, which is infiltration, which is liquid in the lung. And you can imagine that these people have problems breathing, and then they usually go into an acute respiratory distress. And about 10% of these cases were fatal at that time. So this physician made its way for a wedding into the Hotel Metropole here in Hong Kong. And he came from southern China, Guangzhou province, city Guangdong. And this index case is supposed to be the start of what became the first pandemic in this millennium. And you can see the countries that were involved, largely involved in this, and Canada was one of them. And since I worked for the Canadian government at that time, we got involved heavily. Because if you remember, Toronto was one of the cities that was majorly hit and shut down, as was Hong Kong during the SARS pandemic. So there were only a few cases in this hotel, and WHO, for who we worked quite a bit, asked us to go in and make an investigation to try to understand how transmission in this hotel occurred. We came about 4 months after the fact, and we had a team of engineers, microbiologists, and then the local universities. And we basically swapped that whole place, as you can see here. We did a lot of testing of airflow, plumbing system. Of course, we were the microbiology part, but it was a big effort at that time to look into the issues, because at that time, plumbing and air systems were heavily favored of being the problem here with SARS. To cut a long story short, we basically swapped that entire hotel, particularly floor 9, where almost all of the cases, with the exception of one on floor 14, occurred. This hotel was a T-shaped building, or is a T-shaped building, and all the cases, with the exception of 2, occurred in this wing, in this part. And 911, room 911, was the room the index case stayed in with his wife. And these arrows indicate the airflow. So the rooms were actually negative if the doors were closed to the hallway. So there was not an easy exposure if someone was in the rooms. and swapping that whole place and using RT-PCR to detect genomic RNA of SARS coronavirus, we were only successful right in front of 9/11. So we think, or the team thinks, that the index case, who was known to have been gone out that night, was already very sick, must have contaminated the area right in front of his hotel room. And then subsequently, people who came shortly after that got exposed to whatever happened in this hallway. There's no records, so we believe it's either vomiting or it's spitting, which was a big problem, or is a big problem in this part of the world, that contaminated the carpet. And even 4 months later, we could still detect genomic RNA, but we could not isolate any virus from that material. Remember that the airflow was from room towards the hallway. Everybody who was in the rooms was not exposed, but those who came later or may have opened their room door, in that event, the airflow reverses and pushes the air into the room. So that was another event that people could have gotten infected. And then these people went back. They were all visitors to their home countries, exposed at that time, and started the pandemic that we know as it is described. Emergence was a huge real estate in the center of Hong Kong. And I don't know if you've ever seen this. I come from a small village in Germany. The biggest city I've ever lived in is Atlanta, which is pretty widespread. But this is kind of amazing. There were 19 towers, and there were about 1,000 people living in each of those towers. There's 35 floors in each of these towers, so this is like a city in a city. This is bigger than most of Germany's cities are, 20,000, 25,000 people in this very, very confined space. And you can see here the building shapes. This was built in the 80s. It's a cross-shaped building with these re-entrance spaces, which actually act like chimneys in terms of the airflow. And so the question was, what happened here in this particular event where we had 300 SARS cases? So the index case had visited in November Block E. They all were numbered alphabetically and had revisited his brother a few days later. And then shortly after that, this epidemic curve occurred. And then following that, it swapped over to the other buildings before it died out. In total, as I said, over 300 cases. What was different was that they were not just respiratory disease. So there was a large proportion of gastrointestinal disease in this particular outbreak, much bigger than known from SARS at that time in general. So this shows you the view of one of those re-entrance spaces. And this is the bathroom window, and this is the bathroom window, just to give you an impression how narrow this is. If you would lean out here and I here, we could shake our hands. So this is very, very narrow and closed from 3 sides, acting like a chimney. And due to the weather conditions, because they don't really have winter like we have, they have all their plumbing and everything runs in these re-entrance spaces. The dirty pipes as well as the clean pipes, and laundry goes into there for drying, everything. This is an extremely busy space. And these spaces played a key role in the transmission in this outbreak. So this shows you a scheme of Block E, Unit 7 and Unit 8. And the index case visited this apartment here in 16. His brother reported that he basically spent on his second visit the whole day in the bathroom with very heavy diarrhea. This patient was immunocompromised. He was a lupus patient and was infected with SARS, unknown at that time. So what we think happened is that he contaminated this re-entrance space. And looking at the wind directions at those days, the wind would have pushed it over to the other unit. because most of the cases actually, and the first cases after the index case, occurred on this site. So the red numbers were all apartments which had SARS infections, and this is kind of how the first events happened in terms of becoming positive. So all first cases, subsequent cases, were in this unit before it crossed over into the other unit. And due to the chimney effect, infectious material was pulled up to the roof of the building. We did a lot of swapping here as well, but all the microbiology failed. But you may, if you really think about what we did, we used cotton swabs to swab. And these big towers and these big walls, it's very easy to miss. We could not find any microbiology evidence of contamination in this whole buildings 4 months after the, this was actually 3 months after the event. But looking at the bathrooms, and this is kind of interesting and may reset your thinking and your mind of infectious diseases. So these towers are actually occupied by middle-class people, by people that have a decent income and can afford certain things. At the time they were built, people would just water their floors, and there were floor drains, and the water would just run into the re-entrance space down the pipes. But then when people moved in with a little bit more money, they wanted a fan. And because there's odors in the bathroom, of course you want to get rid of them. So they built in these fans, and just to give you an impression out of this bathroom, this is the toilet, as you can see. This is the shower. There's a washing machine here, and here's the door. There's almost no space to turn around. So here's the floor drain, and nowadays people do not put water on the floor anymore. They use wet mopping. So the drains were all not primed with water, and there was an open connection to the sewer stack, which brought in odors and all kinds of particles into these small bathrooms. And here's the scheme how this happens. So if you don't have a primed drain, and if you put your fan on, you're going to suck whatever is in the dirty stack into the bathroom, basically right up your nose when you sit on the toilet, and push it back into the re-entrance space. And that could all be demonstrated with tracer gases. And that's how we think this whole outbreak was primed. Through these open drains, not sealed drains, as well as the chimney effect of that re-entrance space. But we still had to explain how these other towers got involved in the outbreak. And what the Hong Kong people had decided is that it was the sewer system. So we tested, first of all, we looked at the cases. And as you can see, most of the cases were facing this inner courtyard. And whenever we visited this place, there was very strong winds in this inner courtyard, which was basically as wide as this room here. So very close relationship, all these towers on this very defined space. The occurrence of the cases facing almost all entirely to the interior didn't make any sense with the sewer system, because that would have most likely exposed people more evenly on those floors. So it highly favored something happening with the airflow in this inner courtyard. So first we used tracer gas. We released it, and then we tried to detect it at the different manholes, and we were unable to do that. So we could not find any support for the idea that sewer systems was involved in the transmission to the other buildings. And then we released tracer gases in these re-entrance spaces and could show that very, very quickly all this material was pushed up to the roofs. And with the wind conditions that were favoring almost every day this particular courtyard, it was pushed back into the interior of the courtyard, and by that exposing the people that were facing the inner side of these buildings towards the courtyard, and by that way explaining how these people got infected. SARS came back in in December 2003 and at the beginning of 2004. Only 4 cases, a potential 5th case. And it started all in a restaurant that served civet cats to people as one of their main menus of this restaurant. So the civet became the bad guy. At that time, Hong Kong decided to kill all the civets that were on live animal markets because they thought that they were the source of SARS coronavirus. Yes and no. They were the source of SARS coronavirus because they were infected, but they are not the reservoir of SARS coronavirus. They were an interim host and an amplifying host for humans. We went back in with our colleagues and looked at this restaurant. And we swapped the whole place to find evidence. The only places where we found evidence for SARS coronavirus RNA was the cages in front where they were keeping those animals because the customers like to have fresh meat. So the animals are alive when you go in, you pick your animal, and the animal will be slaughtered and served, prepared and served to you. The whole restaurant was clean, including the kitchen. But there was a kitchen where they prepared these civets. This was a side of the normal kitchen of this restaurant, and that was the only other place where we find evidence for SARS coronavirus. The civets all came from the live animal market. And there were multiple civet stalls aside of a lot of other stalls. And when we started swabbing, we could easily, and this was after all the culling of the civets, detect SARS coronavirus on the walls, on the cage systems in those civet stalls, whereas all the other stalls, even so the ones adjacent to civet cat stalls, were completely negative. So the civet really was a source for humans to be exposed to SARS coronavirus, but it, as I said, it was not the reservoir. So SARS is gone. Since 2004, no cases of SARS coronavirus in humans. Is this really gone? I don't think so. Chinese and other researchers found then after the civet cat episode, SARS in bats, particularly in the Chinese horseshoe bat. And that's where SARS still hides. And it may not need much to bring it back into humans. But we believe that the direct transmission from bats to humans is a very unlikely event. So it most likely needs another intermediate or amplifying host, such as the civet, to reappear. But this should have been a warning to all in the field of coronaviruses as well as infectious diseases. But funding almost completely stopped for SARS coronavirus a few years after 2004, and no one was interested anymore in doing any of this work. So that's the part in the past. What are coronaviruses? Coronaviruses are common viruses that most of you get during your life. And it causes mild to moderate upper respiratory tract illness. So it's like a flu. So we all, almost all of us, have antibodies to coronaviruses. We have 5 coronaviruses that infect humans. And they're either alpha coronaviruses, S229E, and NL63. These are just names, designations of 2 human pathogenic coronavirus, or beta coronaviruses, which is OC43, HKU1, and SARS coronavirus. Coronaviruses are very prevalent and, among other mammals, among birds. So they infect quite a few species of animals. But they usually only infect one single species. SARS was an exception because it could infect multiple mammalian species in nature as well as experimentally. And since then, people have gone out hunting. Bats became a real target, as rodents do, as reservoir species for harboring viruses and other pathogens. And as you can see, I took this from Drexler et al., which is Christian Drosten's group from Germany, a friend of mine. These are all the countries in black where coronaviruses have been found in bats in nature, either by PCR, most of them are not isolated. These are all coronaviruses that are being harbored in bats all over the world. And the big question is, bats as the source for emergence of new mammalian coronavirus is currently the big threat. It is not a question any longer. And SARS was one out of those bat associations. It needed the civet to get into the humans and causing the pandemic. But it's still out there. And we're coming now to MERS, which emerged in 2013. Another human pathogenic coronavirus. MERS, Middle East Respiratory Syndrome coronavirus, as the name says, is largely found in the Middle East, on this peninsula, on this Arabian Peninsula. Almost all the cases that we know today, which is 184 confirmed laboratory cases with 80 deaths, that's a very, very high case fatality rate, are coming from Saudi Arabia. There's a few cases in neighboring countries, and there have been a few introductions into Tunisia and otherwise into Europe. And in 3 countries, there have been human-to-human transmissions from the index case that was introduced into the country. So this is the current situation. And everybody was expecting or very worried that during the pilgrimage in October, I believe, the Hajj, that this would become a major problem. But it didn't. So this is the current situation on the emergence of MERS coronavirus. This shows you the case numbers over time. Compared to SARS, this is not a pandemic at this point. It's an epidemic that's very focal in that particular part of the world. If you look at some of the statistics in terms of gender and case fatality, you can see here this is a graph from an earlier time point in the pandemic, so it doesn't include all of the cases. What can we conclude? Many of the MERS coronavirus cases originate from human-to-human transmission. But human-to-human transmission needs extreme close contact and is not very efficient. The majority of MERS coronavirus cases are still in males. We don't really know what it means, but it could have to do with the social interaction in those countries and perhaps with reservoir exposure, that males are more prone to be exposed to the animal reservoir. The severity of disease is much higher in immunocompromised and older people. And there is supposed to be a renal component with the disease, which is still a little bit questionable whether it's actually a precondition, because a lot of these cases occurred in dialysis units, or whether this is a cause of the infection itself. This is the CDC case definition, and I'm not going to go through this with you. But just in terms of epidemiology, this is how we work. We have a new clinical syndrome. During an outbreak or an epidemic or a pandemic, we're going to make a case definition because the clinicians, the public health people, need to define cases. And it's usually cases under investigation or suspect cases. And you can see this is quite cumbersome to go through it. Then there are probable cases, which are usually not lab confirmed, but have a history of contact to a lab confirmed case. And then we have the confirmed cases, which is the minority of the cases, and those ones are the lab confirmed cases. And these are the 184 that we know right now. They're all laboratory confirmed. But there will be many, many more out there that we have not diagnosed. One thing that repeated itself with SARS is laboratory diagnosis is still problematic. The same happened with SARS. There's at least two problems. First of all, serology is not very reliable, and there's cross-reactivity with all these other coronaviruses that humans are infected with. And PCR is not very reliable, even so it's extremely sensitive because we don't get the right specimens. You basically need lower respiratory tract specimens, bronchial lavages, in order to detect SARS as well as most coronavirus. And this is what the problems are. These are not the assays. The assays are extremely sensitive and very reliable. It is the material. And in order to get a respiratory, a BAL, a bronchial lavage from a patient, the investigator puts himself to quite some risk. That was very obvious during SARS. And this is similar with MERS coronavirus. This just shows you the disease. You can read this in papers in New England Medical, in the New England Journal of Medicine. But what I wanted to point out, a vast majority of these cases had comorbidities, and they are listed here. Diabetes, chronic kidney disease, chronic heart disease, hypertension, chronic lung disease, obesity, huge problem in that part of the world. Smoking, huge problem in that part of the world. Malignant diseases and steroid use. And the case fatality increases by the number of comorbidities that these patients have. And that's one of the problems that we see. We're in a new era of pathogen discovery, virology, bacteriology. We can sequence a pathogen within no time nowadays. The limited step at the moment is actually to get the specimens, to get the pathogen. Within a day, a virus of about 30 kilodalton can be sequenced completely. There's no problem with this. So this was done very, very quickly by our friends from Rotterdam in collaboration with a scientist from Saudi Arabia. And this was the isolate. It's a beta coronavirus, so we have alpha, beta, and all the humans come from those two sublineages, gamma and delta coronavirus. SARS is in the same group, but actually quite a bit away from this new MERS coronavirus. And there is another human. Here's another human. And where is the other one? This one is a human coronavirus. So this new MERS coronavirus, designated HCOV-EMC at that time, its closest relatives are two coronaviruses sequenced from bats from Africa and Europe. And that was the association to bats. And it's still the only association that we have. There's one paper out that found a small piece of sequence in a bat from Saudi Arabia. But that's far away from being a confirmation. So that is the only evidence that MERS actually might come from bats, even so everybody believes it does. Coronaviruses are beautiful for an electron microscopist and the virologist. So they got their name from these corona-like structures, from these crown structures, which are built by the surface glycoproteins of these viruses. These are envelope viruses. They have a lipid membrane around the genomic that surrounds the genomic material. Very quickly, the receptor was identified by the people in Rotterdam. This is what we currently believe, what's happening. Subsequently to this earlier data, now papers are popping up all over finding antibodies in camels. And they are to such an extent positive that it was almost unbelievable. Up to 100% of these sera from certain areas have very, very high neutralizing antibody titers to MERS coronavirus. And this goes further back. I think the oldest one is from 92. So this seems to be, or something like MERS coronavirus seems to have been in camels for a long time. And what we now hypothesize is that the virus comes from bats, made its way into the camel, maybe goats and sheep, but there's not much evidence, and then found its way into the human species. And so this is currently what people are working on, as well as to find more evidence that bats are actually carrying MERS coronavirus or something very similar to MERS coronavirus. I'll have to go to this. This is just some things. I don't know what the time is. 7:15. 15 more minutes? Yeah. So this is the story of MERS as it stands right now. The facts are we still have cases, but not many. It never made it to the pandemic stage, as predicted by many, but we're not out of it. You know, this virus could change. It is still an RNA virus. It is prone to mutations. So if this virus gains more human-to-human transmissibility, as we're predicting for H5N1, the avian influenza virus, since many, many years, this could still become a huge problem. We have no treatment, and we have no vaccines. That's the current situation we're in. So that's when a lab like ours comes into place. So we're developing animal models to newly emerging pathogens with the idea of studying the pathogenesis and with the idea of developing countermeasures such as therapies or vaccines. So this is our flow chart. We're trying to get the virus isolate, which became a big problem and very political in this particular case. We can discuss that later after this talk if someone is interested. We then usually use a rodent species first to try to get an animal model. If it's respiratory, we go into ferrets because ferrets are very sensitive to human respiratory pathogens, particular viruses. And then for licensing, we like to have a non-human primate model because the FDA, the Food and Drug Administration, likes to have non-human primate models for cases where we cannot do efficacy testing in humans. And if that all doesn't work, we're going to try to adapt the virus to rodents by passaging it from one rodent to the other. Or we use immunocompromised animals and then passage it to make it pathogenic. Or we use alternative species, but very rarely. So that's basically the scheme that we and others are using. At the time this virus became available, which was November 2012, we kind of had a gentleman agreement with the people from Rotterdam that they would do the mice, the ferrets, and cynomolgus macaques. And we would do the Syrian hamster, which is a standard model in our lab, and the rhesus macaque. So we started with the Syrian hamster. We used 2 inoculation routes that are normally always working in terms of developing animal models. And this is just the experimental setup, but I don't want to go into detail here. The bottom line was we never saw any clinical signs in these animals. We never saw any virus shedding. We never saw evidence for virus replication, and no histopathology. And what really threw us off is that these animals didn't even seroconvert to the infection route. We gave it intratracheally and intranasally because this is a respiratory pathogen. If we would have given it intramuscularly, we would most likely have created an antibody response. So that kind of threw us off. But no seroconversion was really unusual that basically meant these animals are not susceptible. They cannot be infected by this route, which is the normal route humans would get infected. We did all the histopathology. This is all clean. And then, when we were almost done with that study, the colleagues from Rotterdam published the receptor for MERS coronavirus, which was clearly different and is a molecule called DPP4, dipeptidyl peptidase 4. So the big question was, does the hamster express this protein? And that's what we quickly checked while this paper was in revision. And you can see nicely staining here in brown for this hamster DPP4. In lungs and kidneys, the key organs, there's a lot of DPP4, but it obviously does not work as a receptor in this animal species. And the same happened to the ferret, and the same happened to the mouse. So we did not have any small animal model. With all that lack of success in our lab as well as in other labs, we went ahead to go with the rhesus macaque model. We have a standard inoculation scheme, which is combined 4 routes of infection: intranasal, ocular, oral, and intratracheal. The reason we do that is the purpose is to get disease. This is artificial, but the purpose is to get respiratory disease, to see if we then can model human disease and can use those models to develop countermeasures. And this is the experimental scheme. I don't want to bother you with this. When we infected these animals, first clinical signs of disease occurred within 24 hours. But they were very inconsistent. Some animals showed a little bit, others were at very weak signs. They were clearly infected, but it all went away in 3 to 6 days. So this was clearly a transient disease, and they all recovered. If you look at X-rays of these animals over time, and these are the areas, you can see the infiltrates over time in this particular animal, which serves as an example for all these animals. This is not massive, so they would not go into acute respiratory distress, as the humans did in the Sars case and as MERS cases do, human MERS cases. There's some other parameters that I don't want to go into in more detail. And then, unfortunately, to do histopathology, we have to euthanize these animals. And this is lungs of these animals on day 3. And I don't know if this comes through. This would be normal lung tissue. All of this is hemorrhagic tissue, infiltrated tissue, very, very wet. You can see here even more hemorrhagic tissue on day 6. There was no other gross pathology in any of the other organs. Then we do our virology. We titer the virus in the different organs, here shown for the lung. We find high titers in these animals of these MERS coronavirus. And then our pathologies to the histopathology. This here, the brown color, is antigen. So this is the protein expressed from MERS coronavirus in the lungs. All these blue cells are infiltrations. This is a normal lung tissue. And you can see that if you look at this and this, it's easy to see that the gas exchange is severely inhibited in these areas, in these affected areas. That shows the situation on day 6. And the big question is, in what cells does it replicate? And that may not say so much to you, but it is type 1 and type 2 pneumocytes. These are the epithelial cells of the lung alveoli. And then here the staining in brown is for the rhesus DPP4, the receptor, and that overlaps with the antigen staining, so that makes the link to the receptor and receptor-positive cells that get infected. We find evidence for virus shedding. That we do with swabs from the nose and the throat. In this case, we only saw shedding through the nasal swabs, so the nasal mucosae, and this is lung wash, bronchial lavage. We did not find any other positive swabs. This is indicative of transmission of these infected animals. And then we usually do gene profiling with our colleagues from Seattle. And the only thing I want to show you here, if you look at these different colors, this is in the lung here. You can see the black dots are non-infected animals. So that's their profiling on this graph. If you look at day 3, all the animals are up here. So there's clearly something ongoing. But if you look at day 6, they're all back to normal. This clearly and nicely shows the transient nature of this disease in this rhesus macaques. Then we had a model. The cynomolgus macaque did not really work as a model, at least not as good as the rhesus macaque. But this is not a perfect model. We have a very short window that we can actually treat and look for efficacy of treatment. But something needed to be done because people were still dying in the Middle East and there was no treatment. So with our colleagues, we tested ribavirin and interferon, which are drugs that are licensed and that have been used for SARS. But the efficacy in SARS is very controversially discussed. There's a few papers out that say it was efficacious, and there's more papers out saying that it absolutely did not have any effect on human cases. We did the necessary cell culture work to show that the drug can reduce virus replication. I'm not going to go into any details of these graphs. And then found out that only in combination of those two drugs we can get concentrations that we could actually give to a human. So we had to combine them. That is not unusual because this is a treatment for hepatitis C as well as a treatment for paramyx, so for respiratory syncytial virus infections in kids. So this was not an unusual finding. We then took out the rhesus macaque model and treated these animals, and this is just the scheme. We treated them for 3 days with both drugs and looked for the clinical signs. The clinical scoring went down. These are the black bars compared to the white bars. If you look at the X-rays, these are the treated ones and these are the untreated ones. You can clearly see less infiltrates. So improved clinical outcome under treatment. And we took all these animals on day 3 because that was the peak of virus replication in this model. And these are the lungs from those animals. This is a treated one, which is basically healthy lung tissue. This is a non-treated one, which shows a lot of hemorrhagic infiltrations, and this is the scores. And there's clearly that benefit. There's further benefit coming from histopathology, which are listed here. So overall, this was the first evidence that there was a treatment, a potential treatment. The problem only is that these cases come so late into the public health system that it would be too late for them to be treated. Nevertheless, the Saudis decided to run a panel of cases with this treatment, but had no positive outcome. The problem was that all of these cases were very late-stage MERS coronavirus infections. And these two drugs will not help at that stage any longer. But it's very difficult to enroll patients early enough because of the problem with the diagnosis. So that's the current status of the treatment of this infection. And I think, how much longer do I have?
2 minutes.
2 minutes. Very, very quickly, to finish off, I can't tell you the full story. So people started complaining. This model is not good enough. And we agreed, this model is not good enough. But how can we get a better model? This is some structural data. I just wanted to mention here that SARS and MERS have totally different receptors. So they're totally different molecules. So they have nothing to do with each other. So if you model the receptor there is one region, if you compare DPP4 for multiple species, where you can see variation. All the rest is highly conserved. So we looked into multiple species to see which ones are the closest to the human. And we found the marmoset to be identical in this particular region of the DPP4. And then decided to use the marmoset as a model. And since I don't have much time now to finish up, because this would be basically the same kind of scenario going through all these different parameters, I just go to the concluding slide of the models. So what we saw when we did the marmoset, which is a small New World monkey, a rhesus is an Old World monkey. Clinical disease was much more severe. We actually had to humanely euthanize 4 out of 9 animals because they were so severely ill. Due to our protocols and approvals, we are not allowed to let a non-human primate die of an infectious disease. So we have to monitor them extremely closely, and when they get to a certain score, they're being humanely euthanized by veterinarians. So disease is much more severe. There's a little shift to a longer disease progression in the marmoset, which gives you more options to treat. We saw systemic infection, which is nice because you can better control, which we don't find in the rhesus macaque. We have much more extensive gross pathology. And what's very, very important for efficacy testing of drugs and vaccines is the viral load in the lungs is 3 logs higher, which is extremely high for a viral infection. And then we had lethality in this model. So this is clearly the better model for doing countermeasure development and studying pathogenesis. And that's something we're doing currently in the lab. So what remains to be done in the future? We certainly need enhanced diagnostics for this MERS coronavirus. According to the CDC, there has not been a single case in this country. But to make physicians aware and public health labs aware of the potential that a visitor or businessman that goes into this region comes back with MERS, that's going to be the job of the CDC, and to be prepared for that particular case to come in, as happened in Germany, as happened in the UK, as happened in Italy, Spain, and France before. And then we need enhanced surveillance. We find camels positive in African countries, in countries surrounding the Middle East. So the question is something like MERS or MERS itself prevalent much more wider than in the Middle East region? That's something that we totally don't know at the moment. We still don't understand the pathogenesis. We don't know if the virus, actually the virus replication, kills the host, or whether it is the immune response of the host to the virus infection that kills the host. I already alluded to this. There is no good treatment modalities. There is this one combination, but it will only help if you give it early in infection. And we're heavily, not just us, working on vaccines, because most of us feel that vaccines might be the better way to go in terms of this disease. Keep in mind that most of the patients in the Middle East are highly immunocompromised, and a lot of treatment options will not go in line usually well with the immunocompromised status of those people. So I'll close here, and this is the acknowledgement slide for the first part, the SARS part. And you can imagine doing these investigations in Hong Kong needed a lot of people. Kind of interesting side note, at the time of SARS in Hong Kong, Margaret Chen was leading the public health efforts. And for those of you who know a little bit about infectious diseases, will recognize that name because she is the current director of WHO. So I had the fortune to work for her, and I can tell you I've never met a tougher woman in business than that lady. So when I occasionally go to WHO, because I have a different job now, she still remembers me from my time, or from our time, in Hong Kong, which are not always the best memories, because we had a lot of fights with her in terms of what we did and had to do and couldn't do. And this is the acknowledgement slides for all the work on MERS. This is our group down in Hamilton, and these are all our collaborators. And all the work down in Hamilton is funded by the Intramural Research Program, which is kind of the opposite side of where your professors get their money from, which is the extramural system of the NIAID. But all your professors and you in the labs here in the universities, and our program reports to one director who is the director of the NIAID, which is Dr. Fauci. Thank you very much.
We have about 10 minutes for questions.
Students, their sign-up sheet is on the back if you want to make sure you...
Yeah, we're going to put the sign-up sheet there permanently, so when you come in or when you leave, the students can sign up there. Question?
Go back.
You said you would talk about the politics this past?
Oh, the politics about the virus. Well, this is unfortunate these days. And I have to say, I'm older than most of you, but I don't feel that old. So it's not that long ago where viruses and pathogens were freely exchanged and where we didn't have all the regulations that we have in place now, particularly when it comes to high containment pathogen. MERS is a level 3, biocontainment level 3 pathogen, by the way, and particularly when it comes to what we call select agent. SARS is a select agent in the meantime. MERS is not. But I don't want to hammer the regulations, because regulations are important and we need the regulations. But the problem nowadays is, in my view, is the intellectual property. And intellectual property is needed. We all know that. But it inhibits the flow of these isolates and other tools in the scientific community. So when this virus was brought to Rotterdam, because this researcher took it without proper permission from Saudi, because nothing was done there on the virus, and he knew the colleagues from Rotterdam. They isolated this virus with no time. Actually, they did already in Saudi Arabia, but they sequenced it with no time. What then happened was Rotterdam put intellectual property on the virus that came from Saudi Arabia. And there it starts. That's wrong in my view, but they did it and everybody else does it these days. This is why these countries of origin don't want to work anymore with the rest of the world, because they get scooped all the time on these things. Happened the same to us with Toronto too, the main isolate from the Toronto SARS outbreak. We worked with a collaborator, and as nice as this collaborator was, at the end they filed the intellectual property without even letting us know. And so intellectual property becomes the big roadblock. And this virus could then not be moved. We were lucky. We were the last lab and the only one in North America who got this virus before it was completely shut down for almost half a year. And you can imagine what that means for public health response. The CDC was screaming for the virus. Give us the virus. We can't do diagnostics without this pathogen. But there was all kinds of legal issues to move this virus into the appropriate laboratories to do public health response. And this is a huge problem that is not just occurring here. It's occurring almost all the time now.
I have a question that relates to this timing issue. You know, what's the, kind of summarize for us what the time frame was here in terms of when you started, when the outbreak started in Saudi Arabia, to the time in which you were able to complete your diagnostics and be able to think about some treatment, and recognizing that the treatment itself is really not perfect because of the fact that you don't have you can't get them can't get the cases back, that's really, so how long did all that take? And what does that mean for subsequent outbreaks?
I think we're pretty far these days and pretty fast these days. So the first cases were reported in April 2012. And the virus was isolated and sequenced around September, October. So that is about less than half a year after that. So there's already a delay, but you have to remember they did not know. There was a couple of cases, no one connected them, and so on and so on. Then everything went very, very quickly, because once you have the sequence, you can make easily PCR. That's no time. You can go back to cases. You can go back to specimens. And they found out that there was a problem. And then within 3 months, they identified the receptor. They sequenced multiple other isolates. They identified the cases in Europe. And that went all very, very quickly. We got the virus in November and started working with it. We had that non-human primate model in about January. December, we actually, I remember, worked over Christmas on that. So, and then we did the first trial immediately after that. It was done in February, I believe, by the end of February 2013, and we reported to WHO that this might be a potential treatment. And then we got a lot of problems with that treatment because all the doctors that were involved in SARS didn't want to use it. And that's where you then have problems, because they said there's no good evidence that it would work. Ribavirin is known for its side effects, and physicians don't seem to like to give ribavirin, at least that's my experience. On the other hand, they give it to little kids, infants that come down with RSV, and they give it for months to HCV, hepatitis C patients. Of course, the efficacy in those two infections is much better documented. That's for sure. So it took quite a while until the first clinical trial was done, and I'm fortunate that one did not turn out to be good. So right now, the cases are not getting treated. Occasional cases are getting treated, but that depends solely on the treating physician and the physician in charge, whether he uses those two drugs or not, because they're licensed and they can get them and they can use them. And that's the current situation. So overall, this was less than a year to come to a treatment or potential treatment, which is, I think, fairly fast, looking at all the problems that we had with the intellectual property and the legal side. SARS was about the same time, but SARS was really an international effort at the beginning. You know, related back to HIV, I don't know how many years it took before we had a first treatment for HIV. So I think nowadays we're talking about months in order to have something if we can take benefit from existing drugs that are already approved by FDA.
How about how long would it take to mass produce either a treatment or a vaccine?
From scratch?
Yeah.
Oh, Jesus. To make a treatment, to make a drug, I believe the pharma industry says it's about 5 to 10 years if you have to design it and if you have to push it through all the testing. And what you need in an emergency situation, but this is really not my field of expertise, is what they call pre-IND investigational new drug approval. So the FDA can give you, based on very limited data, efficacy data, the approval to use certain drugs in humans if there is no other treatment and if it is indicated and necessary. But that you're still looking at years rather than months.
With the DPV4, is the one in camels similar to the one in humans?
Yes. The one in camels, in goats, And in sheep, that's why people are focusing on these two other animal species, are very, very similar or almost identical in those key amino acids to humans, as is the marmoset. So retrospectively, if we would have known that at the time we started, we could have excluded the hamster, the mouse, and all the small animal models that were tried just because of the structural differences.
And in camels, is it still transient?
We don't know much about the camels. What we see is that these camel sera come in, and when we use to test them for what we call neutralizing antibodies, they are skyrocket high. I have never seen something like that in my life. So they have extremely high antibodies, and almost like a high percentage of these camels. We have, I think there is one report now, or two reports, where they actually have been able to amplify genomic material. There's no isolation from camels now. So camels most likely don't get sick or only get very mild disease. There's a few reports that people were exposed to sick camels which had respiratory disease, but that's all epidemiological supports. So the current belief is that the camel might be the amplifying or intermediate host, may not be asymptomatic, but goes through a very mild disease, and then most likely sheds virus through mucosal membranes, urine. That has not been defined. And as you may imagine, doing experimental work in cameloids is not so easy and hasn't been done yet. But that would be needed in order to really define that. But as I said, that is very, very difficult to do.
Yes, last question.
Okay, so thank you. So you mentioned before that several years after SARS, after there was no new case shootout for SARS, the money get cut down. So, but what I'm thinking is maybe there are, for other viruses, they can also become as deadly as SARS before. So when you work with virus, do you have the feeling that you're facing an enemy but you couldn't see where it comes from? That's my first question. And the second question is, where are the government spending the money when it comes to virus study?
Well, the first question is fighting, so to speak, the invisible enemy is something that pops up in a lot of people's talks. Yes, you do to a certain degree, but we have a lot of knowledge these days where, actually epidemics can be predicted. One of the big fields is Rift Valley fever, where rainfall patterns and other parameters are being used these days for prediction of outbreaks, as well as the interaction of veterinary services and human services. Because Rift first starts off in sheep and leads to abortion. If you have abortion in sheep, that should ring a bell. Then you can still prevent human cases and human epidemics. That is Rift. So that doesn't really work for SARS and MERS, which were new at the time and no one knew anything about it. In terms of the money, I mean, we all know that there is not much money for research at the moment. And so the funding agencies have to prioritize. And something like SARS that basically disappeared for the people is most likely not considered worthwhile funding if you have other problems. The problem is that coronaviruses in particular, Bunya viruses, and I'm not a bacteriologist, so I can't speak for that field, they're prone for emerging, for creating and for emergence of new viruses. So I think it is deleterious if you, again, after MERS, we don't know when this is ending, take all the money out, because it's basically predictable when the next coronavirus will pop up. With having so many bats in the world infected with coronaviruses, it will come sooner or later. What happens is if you stop all the research, you're losing all your expertise, because the researchers have to move to other fields to make living. And that's very obvious in the extramural field. We are lucky as intramural people. We still have a budget, a reduced budget, but we can maintain certain programs, even so they may not have the current public health significance and importance. But also we don't do this. So this is the dilemma we are in, that we're pushing things aside that don't seem to be a problem, and then we're losing our skills and expertise when something similar pops up. That's at least what I think is happening.
Yeah, that's particularly interesting, and it's a very fascinating and detailed presentation tonight, Hans. So I want to thank you again for that.